Good evening, doctors. Warm regards from Bayer Oncology. Thank you for joining tonight's discussion on prostate cancer. Today, we have Dr. Ramesh Reddy, sir. He's a consultant medical oncologist from Omega Hospital, Tirupati. Over to you, sir.
Yeah. Good evening, one and all. Hello, sir. Dr. Rakesh sir and Dr. Venugopal sir. Nice meeting you. So, thank you, Bayer, for facilitating this meeting. Without further delay, we'll jump into the topics proper. So, so for the first topic, I would like to invite Dr. Venugopal sir. He will be speaking tonight on reaching new heights in metastatic hormone-sensitive prostate cancer. Dr. Venugopal Roj garu is a consultant medical oncologist at Medicover Hospitals, Hyderabad. So over to you, sir.
Hi everyone, nice to catch up with you all. I thank Bayer for giving me this opportunity. So with that, I'd like to go ahead for the talk. Let me share the screen. Uh, yeah, is it visible?
Yes, sir. It is visible and you are audible, sir. Please proceed.
Yeah. Yeah. So hi everyone. So today I'll be talking on reach new heights in metastatic hormone-sensitive prostate cancer care. Yeah. So basically, we all know that. So this is the prostate cancer landscape where the newly diagnosed metastatic hormone patients after receiving ADT, eventually they progress onto a state castrate resistant phase. So metastatic castrate resistant prostate cancer, basically CRPC. So patients who suffer and die of prostate cancer all have CRPC. So the importance being once the patient develops CRPC phase, so there is a very minimal what we can do in terms of improvement of overall survival with whatever agents available in our hand. So this is the phase on which we can act at the right time in the right best possible way to give the maximum best possible outcomes. So that's what we are going to discuss. Yeah. So to begin with, this is the stampede control arm, ADT alone. So way back that time, that was the only standard of care available for all these patients, ADT alone. And if you see this graph, you can see clearly so the CRPC time to CRPC is around close to 11 months with ADT alone, and the median OS being 3.5 years, 42 months. So with ADT alone. So this was the stampede control arm. So the point being, we can do now much more better. How? So one, so after ADT, then they just tried with the addition of local prostate radiation in the stampede. If you look at the data, those patients who have got less than 4 bone mets with the addition of the local prostate radiation, they have got improvement in terms of failure-free survival and overall survival, with the hazards being 0.56 and 0.64 with local prostate radiation for those patients who have got less than 4 bone mets. But again, those who have got more than 4 bone mets, hazards 0.86 for failure-free survival and 1.12 for OS. So that there is no benefit of addition of local RP for these patients. So that was from the stampede. So with the available systemic agents, we actually have better outcomes now. We actually have more options. So all the data coming from trials from right from 2018 to 2022 in the form of GETUG, Charted, Stampede, Latitude, RS, Titan, Enjamet, and intensification from Peace 1 and Arasense data. So we now have a wealth of data supporting concomitant therapies. So what do we choose? So, and is there a role or who are the ideal candidates? The intention of the reflect. So that's what. And a few words about the agent available in our kit. So charted, we know that docetaxel has changed game that time. So for the high volume patients, addition of docetaxel to the ADT backbone has given good improvement in terms of overall survival, close to 16 months, but only for, again, high volume patients. But low volume, there is absolutely no benefit of addition of docetaxel to the ADT backbone, as we can see clearly, hazards being 1.04 and improvement is almost 0. Okay, so then comes the abiraterone data from. So abiraterone plus ADT plus prednisolone versus ADT plus placebo alone. So basically, as we can see, clear overall survival being the primary endpoint in the latitude, 3.3 median months versus 36.5 median OS. So basically, hazards being 0.6 with the addition of the abiraterone to the ADT plus prednisolone. And the p-value is significant. So abiraterone was the first to show that hormonal treatment can be effective, but most importantly, we should look at treatment of the this data. And we also should understand the recommended dose being 5 mg BD. Even if you use only 5 mg prednisolone, these are all the grade 3, grade 4 toxicities, as we can see clearly here in terms of hypertension, grade 3, grade 4, almost 23%, even if you use 5 mg prednisolone, and hepatotoxicity 9%, hypokalemia 12%. So cardiac disorders are, and fluid retention. So these are all metabolic impacts what we need to actually keep in mind. We want to start a patient on abiraterone, because mandatorily we are going to prednisone as a part of protocol. So moving on to the next agent in our kit, apalutamide plus ADT versus ADT alone, it has been shown that good improvement in terms of progression-free survival as well as overall survival if you add apalutamide to the ADT backbone. 0.48 and 0.65 being the Hertz p-value significant, both in the low volume and high volume. The progression-free survival is also good. And enzalutamide, again, benefit in terms of significant benefit in terms of PFS and OS if you add enzalutamide to the ADT. So hazard being 0.40 and 6 p-value significant. Although these are, if you look in terms of volume, low volume has the p-value, hazards being 0.43, high volume 0.80 for overall survival. But again, in multiple trials, point of debate whether it can be only low volume, but better proven both these. So next comes, is there any role of intensification of therapy with the triplet? So we have the data from two trials. That's one is PEACE-1 and the second one is Haracens. So the PEACE-1, abiraterone addition to the ADT plus docetaxel, standard of is ADT, docetaxel, and plus or minus abiraterone. So this PEACE-1 has clearly shown that, as you can see clearly, standard of care plus abiraterone standard of care, median overall survival in high volume disease is 5.1 years versus 3.5 years for standard of care, hazards being 0.72, and p-value is very significant for OS, meaning that in high volume disease, you could improve the outcomes by addition of the abiraterone to the docetaxel versus docetaxel alone. In low volume disease, definitely median OS is not estimable in both, not reached in both, and hazards are 0.83, p-value not significant. So in low, no benefit of addition of abiraterone to the ADT docetaxel, okay, as much definitely as disease. So this is the topic for today, Haracens. So it's a global randomized double-blind placebo-controlled phase 3 study where close to 1,300 patients metastatic hormone-sensitive prostate cancer called PS01 and eligible candidates for ADT and docetaxel were only included, enrolled, randomized darolutamide plus docetaxel plus ADT versus placebo plus ADT plus docetaxel. So with darolutamide versus without. 1:1 randomization. Primary endpoint being the overall survival, and secondary endpoints are also important in this setting: time to CRPC, time to pain progression, and symptomatic survival. Stratification was done and based on extent of disease M1A versus M1B and M1C. So most importantly, what we should remember is 87% of the entire group has received all 6 cycles of docetaxel, and adverse events between the arms with Daro, without Daro were almost identical. So darolutamide plus docetaxel plus ADT versus docetaxel plus ADT. So from now on, Daro versus placebo. So adverse events between arms were almost identical, and 87%, close to 90% patients have received all 6 cycles of docetaxel. That most of the patients would receive the docetaxel 6 cycles. So if you look in terms of the primary endpoint, overall survival, so darolutamide versus placebo, so trip versus placebo, if you see the overall survival hazards being 0.68 and p-value is significant, so there is significant benefit of overall survival with the addition of the darolutamide in all cohorts, so overall population in all subgroups. And when it was stratified high risk and low risk, so here in this Arasens they have grouped high risk versus low risk as, we know that high risk Gleason score 3, 8 or more than 8, bone mets being 3 or more than 3, and visceral mets. So these are all the high risk patients, and those who don't have are low risk patients. These are so the hazards being 0.71 for Daro versus placebo, and significant benefit in terms of OS for high risk patients. Low risk patients hazards being 0.62. So meaning that it has OS benefit in high risk and low risk patients, irrespective of the risk. And when you look in terms of the key secondary efficacy endpoints, so time to CRPC is significantly delayed with darolutamide plus ADT plus docetaxel versus ADT plus docetaxel, 64% reduction in the CRPC. And subsequently, time to first subsequent antineoplastic therapy is also significantly delayed with the Daro plus ADT plus docetaxel compared to the docetaxel plus ADT. And yeah, so most importantly, what we tend to forget is the PSA response, and depth of PSA response is also very important, as we can see clearly here. So the PSA response, this is overall group. So the PSA response and outcomes by the PSA response they have achieved. So more than 2/3 of patients are they have reached below the 0.2 in the overall study. That's one important. And if you look in terms of undetectable PSA levels, so if you look triplet versus only ADT docetaxel, so at any point of time, those patients, 67% of the patients have achieved undetectable PSA levels with triplet versus almost close to 30%. And more importantly, those who have undetectable PSA, they fare much better in terms of EFS and OS compared to those patients who have detectable PSA. The time frame being 36 weeks they have taken. So hazards being 0.23 time to PSA progression for undetectable PSA versus detectable PSA levels, and overall survival again hazards being 0.37. Meaning that, so it's rather than the treatment effect, here we are just seeing the undetectable PSA. If they are achieved, they tend to have better event-free probability and overall survival probability, meaning the importance of the depth of PSA response. Of course, obviously more with the triplets. And when they looked at the volume, high volume, again, undetectable PSA levels are high with triplet 62% versus 25%, and time to PSA progression, if you see again, undetectable, those who have achieved undetectable PSA versus not achieved. So hazards being 0.20 for event-free probability, and hazards being 0.30, high volume, really significant for high volume. But if you look for the low volume category of the patients, so whether treatment intensification really helps here or not, if you see again, so darolutamide plus ADT plus docetaxel, versus placebo plus ADT plus docetaxel time to PSA progression being the hazards 0.09 significant. Although this is not powered for detecting the same. And OS also hazard 0.34, in that for ideal patients, irrespective of the high volume or low volume, treatment intensification is also looked at, although this trial is not powered for the same. So darolutamide, basically triplet, achieved long periods of no disease progression and also significant improvements to the overall survival. So these are the things to consider. So patient able to tolerate and accept docetaxel. So I think those patients who are able to achieve tolerate chemotherapy, so they should be definitely given the option of therapy. And extent of disease, high volume, high risk. So the likelihood of hormone insensitive clones. So there is a need for intensification, and definitely hard and early prostate cancer will be the cause of the death ultimately. So will docetaxel be an obligation in near future? Much less effective after post ARPI progression. So patient needs to be definitely informed of the available options for getting the better outcomes. With that, I'll stop here. Thank you.
It was a nice presentation, Dr. Venugopal. So, a nice summary of the way multiple armamentarium came into, as well as nice dissection of the Arasens trial. So now we'll move on to the second topic of this evening. So it's about advancing metastatic hormone-sensitive prostate cancer treatment horizons. Darolutamide without chemotherapy, there are not evidence. So I invite Dr. Rakesh Piniti, who is the consultant medical oncologist at Indo-American Basatargam Cancer Institute, Hyderabad, to please take over the session. Thank you.
Hi, good evening to all. Thank you, organizers, for this wonderful platform and opportunity. So the topic at hand for me to overview the data of darolutamide in combination with ADT without chemotherapy. This is the readout of ARONET clinical trial evidence and how it has advanced the treatment horizons for the metastatic HSPC. So these are the standard disclosures from the Bayer. And India, the approval status of darolutamide is for treatment of non-metastatic castrate-resistant prostate cancers and as well as metastatic HSPC in combination with docetaxel. It is also indicated in combination with the ADT for treatment of metastatic hormone-sensitive prostate cancer. So I think the previous lecture by Dr. Venugopal has clearly shown us how treatment has evolved in the past 2 decades. Just to reiterate, early part of the last decade, we were treating most of the patients with ADT alone, which is either a surgical castration or medical castration. And then we have the early evidence from the Charted and Stampede that added docetaxel to the mix of things. And it has shown improvements in both survival as well as secondary endpoints of PSA progression. And we know the difficulties with docetaxel, and that led to the newer ADTs or newer ARPIs, which are the abiraterone, enzalutamide, apalutamide, and darolutamide. And there are several clinical trials, Latitude, Stampede, Archies, Titan, and Arasens. And we have seen the difficulties of maintaining these elderly patients on abiraterone. We have problems with hypertension, metabolic syndromes. Enzalutamide comes with its own problems. So these toxicities are there. And we are moving ahead with much more toxic protocols in the form of a combination of the ADTs plus newer ARPIs plus docetaxel. We have multitude of treatment options now. We have to choose our patients' treatments very carefully now. Again, we have clearly seen in the previous lecture the utility of this triple drug combination in the high volume disease. The high volume disease is defined variably different clinical trials, but the most accepted one is from the Charted, wherein we see visual metastasis or more than 4 bone metastasis, one of them beyond the axial skeleton. And in that particular situation, probably it has a validity, but we are still looking forward to have a efficacious treatment plan that doesn't come with a lot of toxicities. So there is an unmet therapeutic need. We need to offer a differentiated and improved safety profile for our metastatic hormone-sensitive prostate cancers without adding a lot of toxicities. For a fit patient with high disease volume, we have the readout of Arasens trial from the last lecture as well, wherein it had shown efficacy and safety profile in patients with metastatic hormone-sensitive prostate cancers. and that led to its approval in 2023 in India. And let's look at how darolutamide in combination with the ADT alone without chemotherapy can actually improve the outcomes from the global phase 3 study of ARNET trial. So this is the background. Darolutamide also is approved in combination with chemotherapy. This could be especially efficacious for those patients who are having high volume disease and could tolerate chemotherapy toxicities. And the ARNET was designed to evaluate the combination of darolutamide with ADT without chemotherapy. And this could be a new treatment option for those patients who are not willing to take chemotherapy or not fit for chemotherapy. So this is a study design. It's a randomized double-blind placebo-controlled phase 3 study. It included metastatic HSPC, histologically confirmed adenocarcinoma, fair performance status. It has also included some patients with PS2, and randomization is 2:1 to either darolutamide plus ADT versus placebo plus ADT. One criticism of this clinical trial is that in 2021, it is offering placebo plus ADT instead of other combination, doublet combination. But the reasoning is that even in the early part of 2020, much of the clinical practice was still in the hormone sensitive prostate cancer limited to ADT alone. So that is the reality of practice globally. So that is what is reflected in this clinical trial, and patients are randomized with the stratification factors of visceral metastasis and local prior therapy. And again, the primary endpoint of the study was RPFS, radiological PFS, and there are several relevant secondary endpoints. And at the time of disease progression, it becomes open label study design where patients are 100% crossover to darolutamide, and the selected endpoints of overall survival in that open label phase. So this is the patient demographics and baseline characteristics, more or less equally matched between the two study groups. And what is interesting is that nearly 30%, 1/3 of the patient population is actually Asian. And it actually reflected most of the clinical trial practice where we see a lot of metastatic patients in the de novo setup, high volume disease. Nearly 70% of the patients are having either de novo metastatic disease or high volume disease. So this is again representative of Asia specific. We need nearly 30% of patients from the Asian continent. And in India specific, we are looking at about 13 to 14% of patients included in the trials are representative of our clinical practice. So this is the primary endpoint. Again, we can see the experimental group of darolutamide plus ADT. The medians were not reached compared to 25 months in the control group. Hazard ratio 0.54, inferring a 46% reduction in the progression or death. It's a very positive trial. And again, median follow-up duration was nearly about 25 months. So the benefit of ADT plus darolutamide was consistent across very key subgroups, including those patients with high and low volume disease. If you look at the stratification factors of prior local therapy, it doesn't matter if the patient has taken prior local therapy, both of them have benefited, both the groups have benefited. And we can see the medians to the left of the curve suggesting that they have benefited with the combination. Again, visceral metastasis, yes and no. Again, those patients who don't have visceral metastasis have benefited more than those who have had the visceral metastasis, but the study was not powered to find the difference between both the groups. So as again, low volume disease and high volume disease both have benefited with the combination. So coming to the key secondary endpoints, apart from overall survival, where the data is still immature, patients will be followed for survival. Even there is a signal for favorability of darolutamide plus ADT. Other key secondary endpoints, the time to metastatic CRPC, we can see time to PSA progression, subsequent treatment initiation, and pain progression. All of these are very relevant endpoints in our clinical practice, and most of them have benefited with the utility of darolutamide plus ADT. So this we can see the time to metastatic CRPC. The median was not reached in the experimental group compared to 14 months in the control group. Hazard ratio 0.40. This was statistically significant. And time to pain progression, again, not reached in the experimental group compared to nearly 30 months in the control group. And hazard ratio 0.72, again, statistically significant. So again, it comes with other key secondary endpoints. The PSA undetectable levels are much more common to find in the experimental group at around 63% compared to about 18 to 19% in the control group. Again, these PSA responses are durable. Time to PSA progression was not reached at 25 months follow-up period compared to about 17 months in the control group. Hazard ratio 0.31, very much statistically significant. So again, whether the patient is having a high volume disease or low volume disease, the PSA undetectable levels were noted a higher proportion in the darolutamide group. As we can see in the high volume disease, this ranged from 44% at 24 weeks and nearly 54% at any point, saying that the delta of nearly 30% compared to that of the control group. In low volume disease, this percentage is even better, 72% to 82%. Again, the delta is maintained even better in the low volume disease. So coming to the patients with subsequent systemic therapy, we can see a delta of nearly 10% between the darolutamide group and placebo group. Again, this is a reflection of higher proportion of patients progressing in the placebo group. As we can see, patients in the darolutamide arm going on to receive chemotherapy, enzalutamide, and other radionuclide and olaparib treatments. Again, suggesting that most of these patients have preserved performance status to take subsequent treatment. So coming to the treatment emergent adverse effects, we have seen in the previous lecture how much of a problem the hypertension, other metabolic syndromes are there with the other ARPs like abiraterone. Here we can see that the treatment discontinuation because of the darolutamide was only about 6.1% in the experimental group compared to 9%, even higher in the placebo group. Again, median duration of treatment duration was about 24 months in the darolutamide arm compared to 17 months in the placebo group. So coming to the other common adverse effects, as we can see, most of the adverse effects are actually better in the experimental group. And the fatigue, which is supposed to be much more higher with the ARPIs, we can see that fatigue is actually lesser than that of the placebo at 5.6% in the darolutamide group compared to 8.1% in the placebo group. So these are the other important adverse effects that we see with the other newer ARPS. So we can see the cardiac arrhythmias, the coronary artery diseases, bone fractures. Most of these are life-threatening, and we can see much of them are actually similar to what we see with the placebo, suggesting that this is not only an efficacious treatment plan, but also much safer. And this, again, when cross-trially compared with other drugs like enzalutamide and abiraterone, looks like much safer drug. So this also comes with a very positive impact on the health-related quality of life. And we can see the darolutamide utility extended the median time to deterioration of fact pain questionnaire by nearly 5 months. Again, it has actually impact on the other well-beings, again, social, family well-being, functional well-being, and urinary symptoms. Most of these symptoms and well-being questionnaire were actually in favor of using the darolutamide group. So this is a very brief conclusion of my readout of Arnold trial. The darolutamide plus ADT significantly improved the radiological PFS in patients with metastatic HSPC, and it has shown benefit across all secondary endpoints. Most of the subgroups, both the low volume disease and high volume disease, have benefited with this combination of darolutamide plus ADT. Again, it is associated with a deeper and sustained PSA responses. It is one of the AR inhibitors to demonstrate clinical meaningful delays in both pain progression, functional well-being, social well-being, and urinary symptoms. And it comes with much favorable safety profile. Again, darolutamide with ADT without docetaxel is an additional standard of care for metastatic HSPC. So with that, I conclude my brief overview. Thank you. Thank you very much. Any questions, I will be happy to take. Thank you.
That was a nice elaborate presentation of our Renault trial and a briefing of the quality of life issues also along with that. Thank you, Dr. Rakesh. So now we will move on to the next topic. Yeah. Shall I share my screen?
Yes, sir, please.
Am I visible now?
Yes, sir. Slides are visible.
So yes, we'll go to the presentation. So my topic given to me is case presentation based practical considerations in the management of hormone sensitive prostate cancer. The previous two speakers have made my job easier. So the main practical consideration which we all face as medical oncologists is like when the urologist is going to send us the patient. So at what phase he would have castrated him or started him on bicalutamide or relapsed after that. So this is one major consideration which we are facing day in and day out. And apart from that, the second thing is what drugs to be chosen at what point of time, or what intervention to be chosen at presentation. So categorizing them as low volume disease, high volume disease, high risk disease will help us to offer the treatment approaches that are best possible. And definitely assessing chemotherapy eligibility and other androgen receptor blockers, second generation drugs, whether they are eligible both financially as well as clinical parameters is important. So one thing which comes to our this thing is screening is abiraterone. We have to use some form of steroid, which can actually be troublesome in cases of old elderly osteoporotic males, uncontrolled diabetes, and patients who have kidney issues with dyselectrolytemia. This definitely poses a problem. Enzalutamide, definitely patients who had a history of seizure or CNS disease, definitely it will be troublesome to use there. The other two have a little effect on the cardiac profile, but choosing the patient based on their clinical parameters is important. So I'll jump into the my two of my cases where I had to have a clear discussion with the patient and go on. This was a 60-year-old male with stage 4 prostate cancer. He was an asthmatic, diabetic, uncontrolled diabetes, and osteoporotic, as well as he had a history of epilepsy on anti-epileptics. So he underwent bilateral lumpectomy outside and presented to us with a PSA of more than 150. And this was his initial PET CT, where patient had a prostatic lesion, non-regional lymph nodes, and multiple bone lesions as well. So after discussion with the patient, he was not willing for docetaxel based this thing. He was already obese and he doesn't want to have side effects of the chemotherapy. So we went with secondary and androgen deprivation therapy. He has already completed. So iron out we added darolutamide because abiraterone, again he had uncontrolled diabetes and obesity, and so we offered him darolutamide. So after 4 months, after around 3 months, during the fourth month, PSA reduction was seen significantly, and after 3 more months, after 3 to 4 more months, patient PSA became very negligible. So later he was planned for prostate RT and continuation of darolutamide, and prostate only RT after discussion in the tumor board. So now patient achieved CR after a period of 8 months, and now his PSA is undetectable, and he is on continuing darolutamide without any significant alteration in his day-to-day activities, and well controlled diabetes and other ailments. So the second patient, who is again another 60 years male, who had underwent bilateral lumpectomy outside and came to us with bone scan suggestive of bone mets, and he had non-regional lymph nodes too. So this patient was also started on darolutamide, mainly because of his unwillingness to chemotherapy because of his uncontrolled diabetes, and patient was not willing to go with enzalutamide or other things. Enzalutamide mainly because his family history, he had epilepsy, he doesn't have. So after listening to them, listening to side effect profile, he was not willing for that. So we started him on darolutamide again. So this was the initial. The initial scan is downwards. So there is significant decrease in the size and PSA mobility of the previously documented lesions. PSA PET after around 4 months of darolutamide. So we had difficult decisions here, and we had to offer darolutamide. One darolutamide and apalutamide, these are two beautiful drugs where minimal interactions with other parts are commonly seen. So these were my experiences regarding uh, this practical considerations. Now the house is open for discussion. Dr. Rakesh, Dr. Venugopal, you can share your practical insights on how you would be choosing your patients' uh, treatment patterns. Dr. Venugopal.
Hello.
Hi, sir.
Yeah, hi, Dr. Ramesh. Good. Yeah,
Yeah.
so basically, yeah, I mean, coming to the topic, who gets triplet therapy? That's what we want to discuss. So, what ideal candidates, in my opinion, will be like de novo metastatic disease, high volume, visceral Mets patients, those who have got symptomatic disease like bone pains, impending complications, all that, and young patient. I mean, young means in the sense relatively young, fit
Yeah.
patient with ECOG 01 and fit enough to receive chemotherapy with good marrow reserves and liver and renal parameters, good organ function. So this is the actual subgroup of patients where on a realistic basis I will be favoring them for the triplet ADT, docetaxel, Daro. So yeah, so triplet therapy, I look at all these parameters, then take a decision because they should be fit enough to receive chemotherapy with good organ function, good PS, and if you look in terms of disease parameters, high volume, visceral metastasis. So these are all. Yeah, anything you can add?
Yeah, Dr. Rakesh, your insights into this. Have we missed anything?
I think Dr. Venugopal has clearly mentioned most of the parameters, and I think the differentiation between de novo and recurrent metastatic is something that we need to keep in our mind when making this call. I think most of the de novo metastatic disease is going to behave much more aggressively than a recurrent disease. I think the baseline histological parameters of Gleason score, again, the PSA, again, if the PSA is definitely not risen, then we will be a bit more skeptical about using only the doublet. Probably there is a poorly differentiated component that may not respond well with the ADT alone. So histological, I think we should move away from most of the volume-based characterization to some sort of a biology-based characterization. I think some of the biomarker-based testing is what is needed to make that difference between the triplet and doublet treatment. So I'm for now looking at the volume of disease and the de novo metastatic disease as something that to choose between doublet and triplet, but things can move beyond that. And hopefully in the coming few years, there will be some biomarker that can differentiate between a rapidly progressive disease that requires triplet versus something of an indolent disease that may be treated with a much more simpler doublet treatment.
Yeah, well summarized, sir. Hope we get that biomarker which can differentiate the treatment options clearly. So, if the house is open for discussion, if there are any questions, the speakers will take, or else we'll wind up this session.
Yes, sir. Let me check the
Yeah.
chat box if any questions. Yes, sir. I don't see any questions in the chat box.
Yeah.
So
Okay.
we can conclude the
So,
session.
yes. Thank you, Dr. Rakesh, and thank you, Dr. Venugopal, for being in this meeting and enlightening us. And thank you, Bayer, for the Nebeca division for facilitating this meeting. And have a happy good evening. Thank you.
Thank you, doctors.
Thank you.
Thank you.
Thank you, sir.
Thank you, doctors.
Thank you.
Thank you, Dr. Ramesh, sir. Thank you, Dr. Venugopal, sir, and Dr. Rakesh, sir. Thank you, all the audience, for patiently listening. With this, we can conclude this session. Good night, sir. Thank you.
Thank
Good
you.
night. Yeah.
Okay, sir, we are closing the session.
Yeah, please
Yes.
close this session. Thank you.